Assalamu alaikum. In this presentation, we will be talking about sepsis and septic shock. Sepsis remains a major challenge for intensive care clinicians, researchers, and healthcare systems worldwide due to its high mortality rate and ongoing challenges in early identification. Sepsis is the primary cause of death from infection, especially if not recognized and treated promptly. Its recognition mandates urgent attention. Sepsis is characterized by dysregulated host response and the presence of organ dysfunction, and this sepsis-induced organ dysfunction may be occult, so any unexplained organ dysfunction should thus raise the possibility of underlying infection. These are old definitions. Systemic inflammatory response syndrome is defined as temperature more than 38 or less than 36, heart rate more than 90, respiratory rate more than 20, or PaCO2 less than 32, white blood cells more than 12,000 or less than 4,000, or bands more than 10%. Sepsis is defined as any two or more of the four SIRS criteria plus a source of infection. Severe sepsis was defined as sepsis plus organ or tissue dysfunction. Septic shock was defined as severe sepsis plus hypotension refractory to fluid resuscitation. Now, sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. This organ dysfunction is defined as acute change in the total SOFA score, which we will talk about next, a change in the total SOFA score of 2 or more points consequent to the infection, and a change in SOFA score of more than 2 or more points reflects an overall mortality risk of approximately 10% in general hospital population with suspected infection. The baseline SOFA score can be assumed to be 0 in patients not known to have pre-existing organ dysfunction. Now, septic shock is now defined as a subset of sepsis in which underlying circulatory and cellular or metabolic abnormalities are profound enough to substantially increase mortality. It has a hospital mortality rate of more than 40%, and it's clinically defined as sepsis with persisting hypotension requiring vasopressors to maintain a mean arterial pressure of more than 65 mm mercury and having a serum lactate level of more than 2 millimole per liter or 18 milligram per deciliter despite adequate volume resuscitation. Now, the SOFA score, it consists of 6 body systems, and every component has a score from 0 to 4. The respiratory system is reflected by the PF ratio, which can be obtained from arterial blood gases. The PF ratio, if it was more than 400, it gets 0 score, less than 401, less than 302, less than 200 with respiratory support 3, and less than 100 with respiratory support, it gets 4 points. Coagulation, it's represented by the platelet count. If it was more than 150, it gets 0, less than 151, less than 102, less than 53, and less than 24 points. Bilirubin, if it was less than 1.2, it gets 0. Between 1.2 and 1.9, it gets 1 point. From 2 to 5.9, 2 points. From 6 to 11.9, 3 points. And more than 12, it gets 4 points. The cardiovascular system, represented by the mean arterial pressure, if it was more than 70, it gets 0 points. Less than 70, 1 point. If the patient required support with dopamine, low-dose dopamine or dobutamine at any dose, it gets 2 points. Dopamine from 5.1 to 15, or low-dose epinephrine or norepinephrine, it gets 3 points. And high-dose dopamine, epinephrine or norepinephrine, it gets 4 points. The central nervous system, it's represented by the Glasgow scale score. If it was 15, the patient gets 0 score. From 13 to 14, 1, 10 to 12, 2, 6 to 9, 3 points, less than 6, it gets 4 points. The renal system presented by creatinine or urine output. If the creatinine was less than 1.2 milligram per deciliter, it gets 0 points. 1.2 to 1.9, 1.2 to 3.4, 2 points. 3.5 to 4.9, 3 points. More than 5 milligram per deciliter, it gets 4 points. It can be replaced by the urine output. It gets 0 score if it was more than 500 ml per day, and if it was less than 500 ml per day, it gets 3 points, and if it was less than 200, it gets 4 points. Now, the quick SOFA score, sometimes evaluating all the 6 components of the SOFA score can be time-consuming, and some of them require laboratory measures. A new rapid bedside score, which is the SOFA score, identifies patients at risk of sepsis outside the ICU, in emergency departments and wards. Patients showing 2 or more of systolic blood pressure less than 100 millimeter mercury, or altered mentation, or tachypnea, respiratory rate more than 22 per minute, must be screened for sepsis. Now, sepsis can sometimes be present without a quick SOFA score of more than 2, when different forms of organ dysfunction occur, like hypoxemia, renal failure, or coagulopathy. And patients may have a quick SOFA score of more than 2 without infection, which has led to much discussion and controversy in recent times about the effectiveness of a quick SOFA score.